Tennessee, Mr. Kubler, and please proceed.
Good afternoon, Ranking Member. Good afternoon, Ranking Member Corker and Senator Wyden. Thank you for having me here today. I'm grateful for the opportunity to testify regarding aging in place and the associated healthcare technology, which has such a significant impact on the quality and dignity with which our citizens receive healthcare. My name is Richard Kubler, and I'm responsible for the telehealth program at the University of Tennessee Health Science Center in Memphis. Our program is nearly 12 years old. It's one of the oldest programs in the country. And I personally have worked in the telehealth environment for the last 10 years. We've seen telehealth or telemedicine or e-care work across a myriad of specialties, and we use telehealth as a clinical delivery mechanism over distance. Telehealth can be as simple as remote glucometer monitoring or as complex as real-time diabetic retinopathy diagnosis. However, the results are the same. Telehealth as a delivery mechanism for healthcare works. We see a diverse scope of patients, and since Tennessee borders more states than any other state, our providers are able to see patients from any of the 8 states bordering Tennessee. Patients see no discernible difference between the levels of care. One provider was actually stunned when at the conclusion of a consult, the patient stood up to shake his hand despite being 200 miles away. We've seen telehealth save lives, increase the quality of life, and treat chronic diseases across our state and our region. Telehealth, specifically delivered remotely into the home, has had a significant impact on health outcomes and cost savings. We at UT have the research outcomes that show home-based telehealth used on an at-risk population for congestive heart failure decreased hospital admissions by 80%. Hospital readmission rates were reduced by 85%, and as a result, the cost per patient dropped from $10,000 to $2,500. Nationally, there are 5 million hospital days per year for congestive heart failure, costing approximately $8 billion. The national implications of utilizing telehealth in this single specialty could reduce healthcare costs by $3.8 billion. University of Tennessee Health Science Center in Memphis, we've developed the only real-time diabetic retinopathy technology program in the world. Diabetes is an epidemic that affects 21 million of our citizens and 20% of Tennessee's population. An additional 7.5 million people across the country have prediabetes. Diabetic retinopathy is the leading cause of blindness among adults in the industrialized world. And currently, in the United States, 400,000 patients are screened for diabetic retinopathy each month. Traditionally, the screening is done as a store and forward, and the results are returned taking as long as several days to a week. The patient then has to be rescheduled, and then the diagnosis delivered. Utilizing digital imaging and highly advanced computer algorithms developed with Oak Ridge National Labs, we've been able to deliver those results within 90 seconds, drastically saving costs and increasing the efficiency of patient care. Now, there are associated costs with telehealth, not the least of which is connectivity. And the FCC, as they mentioned earlier, has several programs which subsidize connectivity into rural and underserved areas, offsetting the cost of rural-based broadband by up to 85%. While existing home monitoring technologies may not be bandwidth intensive, the access of broadband at home can establish a platform for ancillary medical services such as clinical video conferencing, education, and medication management technologies. The expansion of wireless 4G technology or traditional land-based fiber optics would have significant impact on the level of care delivered to the home or the last mile. Successful business models for telehealth is direct contracting between service providers such as UT, the Health Science Center, and managed care organizations. In the case of maternal fetal medicine and pediatric cardiology, providing blanket service for a regional population can provide cost capitation for the MCO while also covering the cost of delivering telehealth services into outlying or even metropolitan areas. However, the most significant barrier to adoption is reimbursement. In the previous real-world examples I gave you of a telehealth application with both chronic heart failure and diabetic retinopathy, there's no reimbursement for providing these services. When left to altruism alone, there's little hope of a sustainable business model for telehealth or e-care. In most cases where telemedicine practices are reimbursed, it's done on a lower scale than a traditional brick-and-mortar patient encounter. So if a provider is reimbursed 2 to 3 times as much for a traditional clinical encounter versus a telehealth encounter, which type of healthcare is incentivized? Telehealth is actually disincentivized for both providers and facilities in the current fee-for-service model. And while reimbursement varies from state to state, the successes of telehealth implementation from a billing standpoint have been the inclusion of telehealth as a traditional method of care, whether delivery of healthcare into the home or the extension of specialists into rural and underserved areas. There must be an equitable billing mechanism for telehealth to be sustainable. Currently, telehealth is reimbursed as an exception or a less than method of care delivery. In states such as California or Missouri, they've incentivized the practice of telehealth by state Medicaid provisions, which reimburse equally for telehealth services which meet certain technical criteria. Telehealth should be viewed as an accepted level of care versus an exception to the rule from a reimbursement standpoint, whether delivering care into the home or treating a patient in a rural or metropolitan clinic. At UTHSC in Memphis, we've seen the opportunity and radical improvement to health care that telehealth can afford. The implications go far beyond the quality of life for our aging population, preventing hospital stays and nursing home enrollments. The significant cost of health care for our aging population is undeniable, and we have demonstrated that the cost savings exist. Ultimately, a model must be created to ensure that telehealth care providers are equitably reimbursed, otherwise there's no incentive to change traditional delivery of care. Telehealth is not a panacea, and like any other form of healthcare practice, there's potential for abuse. However, the potential of healthcare possibilities is almost limitless in the ability to provide quality medical care over distance. Ranking Member Corker, Senator Wyden, thank you for the opportunity to speak with you about the incredible opportunity that faces us regarding advancing the level of healthcare in our state and our country. I'm happy to answer any follow-up questions you may have.
Thank you very much, and Senator Corker's been so wonderfully patient all afternoon. I think it's just appropriate he start the questions.
Well, I will then.